Hello, everyone. Welcome to Being Patient Brain Talks. I'm Deborah Kahn, founder of Being Patient. Today, we're going to talk about the diabetes drug, semaglutides. A lot of you may know them by the name Ozempic, which was probably one of the older ones out there, more commonly spoken about. They are now being studied as a prevention, a possible way of preventing Alzheimer's disease. I thought we should take a deeper dive into these drugs. What do we know? What don't we know? Joining us is Dr. Heather Ferris. She's from the University of Virginia, and this is a area of her expertise. Heather, thank you so much for joining us.
Thank you so much for inviting me.
Okay, let's just start with the basics. What exactly are semaglutide drugs?
Yeah, so they are part of a class of drugs called GLP-1 receptor agonists. And GLP-1 is a hormone that your gut makes after you eat a meal. It's one of these hormones that tells your body nutrients are present. It helps to give you that signal that you're full, that you've eaten. And it also helps to stimulate your pancreas to control your blood sugars. So these drugs are mimicking that hormone, and they've been made longer acting, so they stay in your system for a longer period of time. And they're really designed to do those two things, to stimulate that pancreas so that it controls blood sugars better over even when you're not eating, and then also to tell your brain, I've eaten, I'm full, I don't need to eat more. And so that's why they're used both for diabetes and for weight loss.
So it secretes this hormone that basically says, okay, I'm not very hungry. I mean, I guess you have to be a little bit hungry, right? You don't want to not eat. So it just really is that impact greater than actually like the way that glucose is metabolizing within our systems, or is it kind of in tandem, side by side?
Yeah.
It has an effect.
So the glucose itself doesn't tell you you're full. It's and it doesn't, just like we don't really differentiate if you're eating protein or if it's a carbohydrate. Like your brain doesn't say, oh, I feel more full because in the moment because of one or the other. Later on you do, because they stick around for different amounts of time. But it's these hormones from your gut that actually feed back to your brain to say nutrients are received.
So it's actually so that just makes people eat less, and that's why. So for diabetes, for example, it's like, the drug was first, I think, used for diabetes. It wasn't, weight loss came later as an impact that it had on patients. But in the case of diabetes, it wasn't diabetics should just eat less and that will help you, but with your, like, how does that all work in with the disease lens on, and what is it actually doing for diabetics?
Yeah, so type 2 diabetes is sort of a combination of you're not making enough insulin, and the insulin is not working as well as it should because you're resistant to insulin. And so weight loss helps reduce that insulin resistance. But so the weight loss helps in managing diabetes, but this also has a direct action on the pancreas. And so it tells the pancreas, it's signaling to the pancreas to make more insulin because the blood sugars are elevated. And that helps to overcome that resistance. So it's actually it's interesting when we use these medications at lower doses, they're really effective at bringing blood sugars down. And then it's at higher doses that we start to see the appetite suppression and people starting to lose weight. So, so that we have this immediate response that's really impactful for diabetes. But it's a really smart drug. We have, we give people insulin injections all the time, but those can cause low blood sugars. The way it works up at the pancreas, it only makes your pancreas make more insulin when the sugars are high. So it doesn't cause low blood sugars. That's why we can use it in people without diabetes as well.
Okay, and we know that we're going to bring this back to the brain, but we know that obesity and diabetes, right, is a
Mhm.
risk factor for Alzheimer's disease. I mean, it's in a lot of cases it's called diabetes type 3. Alzheimer's is because of the relationship. Um, let's first start with the obesity part of it. Would you say if a person is overweight, a better option is really, I mean, to take one of these drugs because that's going to make you lose the weight, and that's therefore going to minimize the risk of diseases like diabetes and Alzheimer's.
Yeah, so what's right for any individual is always, that's a discussion with your physician. It's going to be different from person to person, but we know that in general, people who lose weight have less of these chronic disorders, heart disease, neurodegeneration, diabetes. But we also know that lifestyle change is really hard. Our brains, our bodies were not built for this environment where we have so much around us. We're designed for an environment of scarcity. So, there's no reason why your body would say, oh, you have too much nutrition, we should stop down, right? Because it that may go away. And that used to be the case, that there was sort of, harvests and then famines. And so our bodies are designed to hold on to calories. So when you gain weight, your all those hormones are saying, okay, this is great. This is my new happy weight. And then when you lose it, your body starts fighting you. And that's why weight loss is so hard, and why people tend to yo-yo back and forth, is because as you lose weight, that those hunger signals increase. So things like the semaglutide drugs, they help suppress that drive to eat. So people talk about the food noise. It takes away that food noise. Oh, I really, thinking about food because I haven't eaten in a while. And so it really dampens that down for people and makes it more sustainable.
So, talk to me a little bit about glucose metabolism. The way that I understand it is, glucose is a main source of fuel for our brains. As we age, I've been told we don't metabolize glucose as efficiently as, we did in the past. So, would these drugs possibly really help in terms of really kind of boosting the efficiency of metabolizing glucose, which we know would be good for our brains?
Yeah, so I think that there's kind of a couple of different pieces to that. So we make less insulin as we age. Our pancreases wear out like our knees do. And so this boost helps that. And insulin, what that does is it unlocks your cells and lets the glucose in so that it can be used. So it's definitely helping in that aspect. Whether it's helping at some of the other parts of glucose metabolism is a little bit trickier to understand. Your mitochondria are very important for breaking down glucose. Those also accumulate damage with age. So there are lots of other steps, but clearly you get the boost from more insulin, and then you also get that boost from reducing insulin resistance. That just has a lot of toxicity. The same fats and that are causing insulin resistance are generally not healthy for your cells. And so I think, yeah, the benefits are manyfold.
So, what do we know about Alzheimer's prevention and semaglutides? What has research told us? I know you're also studying it in your lab, so tell us what we do know and what more we need to find out.
Yeah. So I'd say the strongest data that we have right now is in people with diabetes. So we have these drugs have been around for over a decade now. And we can go and look into the epidemiologic evidence and see, okay, these are the people with diabetes who took these drugs, and these are people with diabetes who didn't. And the ones who took these drugs have less cognitive decline. And so that right there, obviously, is a tremendous outcome. But this isn't people with diabetes. And so studying people without diabetes requires actually more of like prospective, looking forward studies. So those are starting to happen. We had a very recently, just last month, there was a study released with an earlier generation called liraglutide. And this is rather than a once weekly drug like Ozempic, this is a daily drug that is, again, used for either diabetes or for obesity. And they had 100 people in each group. And these were people who had early Alzheimer's disease. The paper actually hasn't been fully published. It was just announced at a meeting, so I haven't seen all the data yet. But again, these were people without diabetes, but who had cognitive decline and were thought to have Alzheimer's disease. And they saw less brain atrophy in the people that took the liraglutide, and they saw some reduction in cognitive decline. Interestingly, there was no difference in glucose metabolism. So, what these drugs are doing exactly is really hard to say. Yeah.
So I wonder why there would be less brain atrophy. Is there any hypotheses you would have to explain that?
Yeah. So there's been a lot of work in mice and in cells in dishes to suggest that these drugs protect neurons from cell death. The confusing part about those studies is that there's not very much of these drugs that actually get into the brain. So I told you that that these drugs signal to your brain to stop eating, but that part of your brain called the hypothalamus that controls appetite is really a very special part of the brain that it sees the blood circulation much more than the rest of the brain. So these drugs are really large. They don't cross the blood-brain barrier very well for all the rest of it. And so we don't know really, is there enough getting in there to really hit? There's the receptors, the receptors for GLP-1 are in the brain. So they should be there for some reason. But these drugs don't get in very well. So I think it's still an open question as to whether the benefits that we're seeing are from the drug directly getting into the brain and affecting neurons and increasing their survival, for example, or again, if it's just a healthier metabolism overall, and that is benefiting the brain in some indirect way.
Now, maybe what you could do is tell us what is the direct link between metabolism and brain health? What do we know in terms of metabolism?
Yeah. So I think, again, I'll reference a clinical trial that I think demonstrates it really well. There was in Finland several years back, they had a clinical trial where they had patients, they were all older adults who were at risk for developing dementia. So they didn't have it, but they had risk factors. And they put these, half of those patients, they put into an intensive lifestyle intervention. So they got nutrition counseling, they went to the gym, had supervised exercise several days a week. Their nutrition counseling was through group exercise or group teaching. So they had social interactions, which we know is really important for the brain. And then they had them do some brain games too. And so this intervention was for 2 years. And at the end of 2 years, they saw that the people in this intervention group had a 20% less cognitive decline than the controls. So again, and this is always the hard part about anything related to nutrition and metabolism, is it's not just one piece, right? So is it the food? Is it the exercise? Is it the social interactions? It's really hard to separate these things out. But we know that these lifestyle interventions can have really a pretty similar degree of effect as what we were seeing from like the anti-amyloid antibodies.
Yeah. Just as a follow on to that question, Cynthia is asking, how does APOE status? We know APOE4 is, of course, the variant that elevates risk for Alzheimer's disease, depending on you have one or two copies. Cynthia is asking, how does APOE status influence metabolism, especially among homozygous, like so people have two copies of APOE4?
Yeah, so I'm going to answer kind of the flip first, which is that we know that people with APOE4 benefit from these lifestyle interventions just as much as people without, and actually maybe even more. So, which is really great news. APOE, so APOE is a cholesterol carrying molecule. It's actually part of LDL cholesterol in your periphery. So we do see changes in cholesterol in people with APOE4 compared to 2 or 3, but that's probably, and in the brain, APOE is the main thing that transports cholesterol. In your blood, you actually have a bunch of different APOEs that all work together, so it's a little different. But the main effects on metabolism are probably these changes to cholesterol. And definitely that's the main effect in the brain.
Do we know about long-term impact taking these drugs? Are there any negative, can people stay on these for the rest of their lives? Like, what do we know in terms of both long-term efficacy and safety?
Yeah, yeah. So as I mentioned, they've been around for over a decade. And something that's unique about the diabetes space is that there was a drug that a diabetes drug in the past that caused heart failure. And so after that, the FDA mandated cardiovascular safety trials for all diabetes drugs, which means that they had to test these all new drugs in tens of thousands of people. So they've actually been studied long term in very large groups of people. So much bigger studies than your typical drugs that get approved. And so we know actually that they're quite safe. They reduce your risk for cardiovascular disease. They reduce your risk for kidney disease. And then again, there seems to be these signals of I guess they reduce cardiovascular disease and kidney disease if you have obesity or diabetes.
But these, I mean, to be clear, it's more a drug to help manage a condition, right? Whether it's obesity or diabetes. So
Yeah.
what do we know about once you go off the drug?
Yeah, so unfortunately, what we know about stopping the drug is that those hunger signals tend to come back. So it's some people are able to wean themselves off these medications. Sometimes it's the help they needed to, lose the weight so they could become more active, and then that facilitated a big change in their lifestyle, right? But in general, we think of these as long-term medications. It's not fixing the underlying problem per se, because our bodies they strive for these higher weights.
And, but for Alzheimer's prevention, maybe it will just be one piece of that puzzle, right? Rather than like it's going to solve Alzheimer's. A lot of scientists out there believe now it's going to be more of an HIV type of treatment where you're targeting different risk areas, managing them. So, to decrease your risk. So this possibly could be, I mean, the research that you're doing, I'm assuming it's not just like a silver bullet, right? It's more, how do we minimize this type of risk that is associated with Alzheimer's disease?
I mean, in the end, you don't care how much plaque you have in your brain, right? You care whether you can remember your grandkid's name. And so that's where I see these drugs fitting in is there's actually not super great correlation between how much plaque you have and how much memory loss you have. And obesity and diabetes are those things that make lower levels of plaque maybe more symptomatic. And so if we can reduce those symptoms, then that's our end goal.
Yeah. What is that correlation though with the plaque? I mean, do we know what the correlation is?
Well, so there is, I mean, there's no question like
And
high.
not for Alzheimer's. I mean, like if you're on a semaglutide,
Mhm.
does that mean that possibly you'll have less plaque or formation, or maybe it's like it's preventing you from reaching the tipping point, and you
Yeah,
still, like, does anyone know that?
I don't think we really know that. Um, I I think I think it's much more plausible that it's just preventing us from that tipping point. It may have some impact on plaque and tangle development, but I think that that's not where most of us see its primary action.
So, the research is obviously coming in and there's more data to be found. But where do you see it fitting in the whole Alzheimer's prevention if proven successful through future studies?
Yeah. So I mean, I don't think that it's a medication that everybody should be on, right? Like, we're all we're we're all potentially at risk for developing dementia at some point in time. We can't all be taking this medication. And right now we don't have the best biomarkers. They're coming, but it's not like cholesterol where we have a really easy measurement. So I think for the foreseeable future, that's going to be a little bit of a difficult question to answer. Um, the trials that are being done right now with semaglutide are in people with mild cognitive impairment. So these are people who are already showing some signs, and we'll be getting those results in the next year or two. And so these will be larger studies, and I think will be really informative as to in the population of people who do not have diabetes and obesity, you know, should we be using these drugs to slow things down? I think the lifestyle part, without doubt, as much as you can do, that that works for everybody and it's safe. And so, as much as possible, we should be instituting as many lifestyle changes as possible. But I don't think we're going to start prescribing these drugs to everybody with a family history, for example.
Yeah. Okay. And then you just Bernadette was just asking, are these tested in people without who don't have diabetes and obesity? But you just answered that question. So
Yeah, and that liraglutide study that I mentioned, this first one that has come out that showed the reduction in brain atrophy, those patients did not have diabetes. I don't know if, again, it's not fully published, so I don't know if they were overweight or, but they did not have diabetes. So and this new study is definitely, it's people without diabetes.
okay, so it's interesting. We're getting more data, so stay tuned.
Yeah.
So thank you so much, Heather Ferris, for joining us. If you missed any of this interview, don't forget to sign up for our newsletter on beingpatient.com. That's where you'll hear about talks like these. Let us know if you have any topics you want to know about. But thanks so much, Heather, for this really interesting conversation. Well, let us know when you discover more with your research. It's a topic I think of interest, both in the Alzheimer's community and also outside. So thanks very much for your research.
It's been great talking to you. Thanks.
All right, take care. See you next time.